Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel, and this week you'll be hearing our extended Q&A sessions from NEI Synapse. Kicking things off tonight is the chair of NEI Synapse, Dr. Roger McIntyre, giving us the highlights of what's to come. Dr. McIntyre, what are you most excited about when it comes to this year's Synapse?
I'm most excited about the format that we've adopted for Synapse. What I mean by that is we're going to have a conventional setting where we're going to be sharing really new information, new pharmacology, new disease areas, and that's going to be shared with a larger group. But we're going to quickly be transitioning back and forth between the open knowledge dissemination with workshop or really debates. I love debates, and I think we don't have enough debates. And we're going to have colleagues debating different topics that are relevant to clinicians who see patients, integrating the best of science with the art of the science, frankly. And I think the debate's the best way to do it. So this year at Synapse, we're going to be talking a lot about debates as well as segueing in our panel. So it's really the delivery method, these debates, our panels, but also our open sessions. I'm very, very excited about it.
What can attendees look forward to at this year's Synapse?
During the last 5 years, psychiatry has changed greatly. Not only are we seeing very new ways of conceptualizing disease states with a shift more towards dimensions or so-called transdiagnostic phenotypes, but the advances in neuroscience are surreal. And this is translating into very new treatments. For example, only in the last year, for the first time in psychiatry, do we have 2 new treatments that were based on a disease model, that being esketamine and brexanolone targeting glutamate and neurosteroids, respectively. What does this mean for people attending Synapse? You're going to be hearing about how the neuroscience is not just helping us understand the disease, but how it's actually informing treatments that can really help patients. So it's going to be the best of neuroscience. And what does this mean for me as a clinician in the assessment, the evaluation, and perhaps even the disease modification of patients that I see? So it's going to be really exciting to integrate that together.
Wow, it seems so valuable. With that, what would you say are just some of the topics that we're covering at this year's Synapse?
Just some of the topics that we're covering are topics related to diagnosis. I have continued to struggle with where's that interface? Does one exist between major depression and bipolar disorder? Where is the interface between cognitive impairment in someone who's depressed and someone who has early insidious onset Alzheimer's or dementing disorders? These are very common questions, and I'm very excited to talk about these ambiguities that we're so often facing in clinical practice. The second part that I think is going to be really interesting is talking about what amounts to a couple of dozen new treatments, pharmacologic treatments. Why were they developed? What's the rationale for developing them? And so clinicians attending Synapse can be assured that no matter which ecosystem they work in, no matter what patient population they work with, the information conveyed is going to have broad transdiagnostic application. And I want people to walk away from the meeting, and they will, with the best of the science and also new pearls to assist them in diagnosing and treating their patients.
Can you share with us a little bit about what some of your upcoming talks are about? Can you give us just a sneak peek about what to look forward to with your talks?
A couple of talks that I'm going to be presenting at Synapse this year, which frankly I really enjoy, is the topic of mixed features. We're going to be debating this in a format. I've taken a tremendous interest in this topic of mixed, not just as an academic and as a clinician, but also historically. There's such an interesting historical conceptualization. And one of the areas I've been really intrigued by is why are we seeing less euphoric patients in psychiatry who have bipolar? Why are we seeing more dysphoric, more irritable patients, more mixed patients? And we're going to discuss why this might be. The other topic we're going to spend a lot of time on is really looking at the neurobiology of dopamine. Now, everybody knows how dopamine, why that's so relevant for us in psychiatry. But where psychiatry is shifting is really greater emphasis on cognition, as well as 2 interrelated constructs, that being motivation and reward. And we're going to talk about how this is not just interesting academically, but how we can do better for our patients, because patient-reported outcome literature tells us where patients struggle with psychiatric illnesses, they don't feel themselves again. They don't have joie de vivre. They don't have a sense of vitality. This comes back to many chemistries, including but not limited to dopamine. We're going to talk about that in one of my talks. And then thirdly, one of the ones I'm very interested in is this interface of cognition. I call cognition too big to fail. It's too big to fail for our patients, and it usually does, whether you have a childhood or adult or later onset condition. We're going to talk about the latest around the neurobiology of this, how to assess it, how to manage it, and how to prevent dementia in patients who have early illness onset with cognitive impairment. So for me, it's going to be, frankly, extremely fun to talk about these topics.
They all sound so exciting. I know you touched a little bit on that debate that you're doing with Dr. Stahl on mixed depression. Can you tell us a little bit more about that?
Well, I can actually preempt it and let you all. I'm going to win the debate. I want everyone to know that. That's the bottom line. I'm going to win the debate. But what Dr. Stahl and I are going to be debating is something which is so interesting to both of us. Dr. Stahl recently led a multi-author guideline on how to conceptualize and treat people who have mixed features. And what Dr. Stahl and I are going to be debating is two sides of this of the argument. One being that the DSM-5, in its good wisdom, has accurately captured what mixed states really look like in the natural habitat in our offices. Secondly, does the DSM-5 actually introduce an inorganic conceptualization? Is it somewhat contrived and artificial? Does it not mimic what we see in clinical practice? So Dr. Stahl and I are going to debate two sides of this argument. First, the DSM's got it right in how they conceptualize mixed, and I'll be taking that position, and then Dr. Stahl will be arguing a different position that DSM-5 doesn't got it right. In fact, they've really missed the mark on this one, and there's different ways to conceptualize it. So it's going to be a lot of fun. I'm confident I'm going to win, but we'll see where things go.
Can you share with us a little bit about what that panel discussion is about? And I know I believe it's the last session. So it kind of wraps up the whole event, but can you share with us a little bit more about that panel discussion?
Absolutely. At the end of the day, as mental health care providers, we treat people, and the science is to inform best practices, but there's no better illustration of concepts and better illustration of how to implement the best of science than cases. So we're going to have during the panel, we've asked colleagues to bring cases, and not contrived cases, not cases that are not representative, but cases that are from their own practices, in cases that are complicated, cases that we struggle with. And this will be really, really fun, because for me, it's not just a opportunity to hear colleagues how they think through various critical decision points, because that's what we're doing in psychiatry, but also it gives us an opportunity to weave in the best of science. So I see Synapse as an opportunity to bring the best of science and also the best of the art. And I've always believed that case-based discussions the panel is going to be adopting is really the art of psychiatry. And nothing's better than hearing colleagues think out loud how they walk through different decision points in the algorithms of treating patients. And that's what we're going to be emphasizing.
Absolutely. I think that's so powerful. What would you say to people who can't make it to this year's Synapse?
First of all, disappointed to hear you can't make it. What I would say is certainly access NEI's website. You'll be seeing some material on the website, which will capture some of the topics. Let me just say that throughout the calendar year, all of us are very busy. Everyone's time poor, and we need to allocate time so preciously and judiciously. And what I would argue strongly is, if you're going to next year be planning, many of us are planning a year in advance, what meetings you're going to prioritize the Synapse meeting. Because I think what they really like is high science, up to date, comprehensive, and really exciting science presented by clinicians who see patients and translating this clinically. And I believe strongly this represents a powerful learning opportunity, not just for knowledge translation, but for changing our behavior best for our patients. So stay tuned to the NEI website. We're sorry we're going to miss you in North Carolina. It's a great place. We're going to be having the meeting. And certainly for next year, etch it on your calendar and hope to see you then.
Can you tell us what makes Synapse different from other conferences?
For me, what's so different about Synapse versus other conferences can be really conceptualized in two ways: the content and the process. First, on the content side, what we are trying to do at Synapse is we're looking at key disease states, key therapeutic areas, in saying, what is the best of science we have right now? Secondly, the process. The process is through, yes, we're going to be sharing information by some of the best communicators, the best educators we have anywhere in psychiatry. But people who see patients are going to be discussing this in debates and panels. And this is what people want. I think many of us attend conferences. We enjoy listening to good speakers, but we walk away not entirely knowing how I can make this personalized to me. The size of the Synapse meeting is significant, but not too big. And the size of the meeting allows us opportunities to interact extensively, not just with colleagues, but also the faculty. And again, too often we'll attend a meeting, it's a very large meeting. We don't have the opportunity to really, in fact, bounce ideas off and really think through ideas with colleagues as well as the faculty. So NEI, I think, really illustrates a wonderful example of really being high neuroscience, but neuroscience is clinically oriented in a way that is accessible, pragmatic, and immediately applicable to practice, and a great opportunity to interact with colleagues. And that, I think, is not just professionally enjoyable and obviously personally very enjoyable, but that's really where a lot of the great learning takes place, is during those interactions. And I think that Synapse will be really a wonderful opportunity for all that.
Thank you so much, Dr. McIntyre. Thank you all for tuning in, and we hope to see you there at this year's Synapse. Subscribe now to hear more NEI Synapse extended Q&A sessions from faculty.